Canada. This is Dr. Hira Burhan, President of the Asian Medical Students Society. We are proud to bring you the online neurotrauma symposium today in association with the World Federation of Neurological Societies and the Asian Congress of Neurological Surgeons. Please allow me to present this symposium for you all. We have a lineup of 4 neurosurgeons who are masters in this field. And before we move on to our talk, let's first introduce our panelists to the speakers. So, Dr. Kabulo, can you please introduce yourself? You need to unmute, Dr. Kabulo.
So let me unmute.
Yeah.
Can you hear me?
Yeah, we can hear you well.
Yeah, I'm saying my name is Dr. Kabulo from Democratic Republic of Congo, currently neurosurgery resident at the University of Zimbabwe under Professor Kalamo.
Welcome, Dr. Kabulo. Next, we have Dr. Duong. Can you please introduce yourself? Unmute and introduce yourself.
Hello, everybody. My name is Kian. I come from Vietnam. I work in Sengpon Hospital in the capital of Vietnam. I'm a neurosurgeon. Nice to meet one of you. Thank you.
Thank you, Dr. Duan. Welcome to the panel. Dr. Warlax, can you please introduce yourself?
Hi, my name is Walalak. I am the last year neurosurgery resident from Thailand. It's nice to meet all of you guys.
Right. And Dr. Burhan Pali, if I'm not wrong in pronunciation, can you please introduce yourself?
Hi, hello, this is Boran Urful from Turkey. I'm assistant professor of neurosurgery. I'm mostly doing neuro-oncological surgery and traumatic neurosurgery. Hello to everyone.
Hello, welcome. Dr. Prashant, can you please introduce yourself?
Hello, myself Dr. Prashant. I come from India. I am a neurointensivist.
Okay, welcome Dr. Prashant. Dr. Ahmad Al-Jaradi, can you please introduce? Dr. Ahmad, you need to, hello.
Hello everyone, my name is Dr. Ahmed Al-Jaradi. I'm final year resident neurosurgery from Yemen.
Welcome, Dr. Ahmad. Dr. Sue Matmo, can you please introduce yourself?
Yes, I am Sumya Mo from Myanmar. Nice to meet you all.
Nice to meet you too. We have Dr. Jeremy. Can you please introduce? Okay, I don't think he's over there. Okay, Dr. Tariq Khan, can you please introduce yourself?
Yeah, hi, Tariq Khan from Peshawar, Pakistan. I'm professor neurosurgery, Northwest School of Medicine, and chairman of the Neurotrauma Committee of World Federation of Neurosurgical Societies. Good to see you all.
Good to see you. He is also one of the speakers for today. And Dr. Parthiman, can you please introduce yourself? You need to unmute, Dr. Parthiman. Dr. Parthiman, you are muted. You need to unmute, please.
Yeah. You able to hear me?
Yeah, we can hear you well now. Yeah.
Okay, I'm from India. I'm a neurosurgeon who is working on skull base and spinal surgery. You can see from my lecture today, you can get to know about me better. Yeah, thank you.
Yeah, thank you and welcome, Dr. Parthiban. Thank you for being a part of today's panel. Dr. George? Dr. George, are you there? Okay, Dr. Herman, can you please introduce yourself? Dr. Herman, can you hear us?
Yeah, I think this is Herman's first.
Okay, so I think we can start with our first lecture, Professor Kazadi Kalangu. Just a note, during the lectures, I request the one who are not speaking to keep their microphones muted so that we do not have any surrounding disturbances. I would like to introduce Professor Kazadi. He is the professor and head Department of Neurosurgery at the University of Zimbabwe, College Health Sciences, and he was past president of the Association of Neurosurgical Societies of Africa. He'll be presenting today on the prevention of head injuries. Professor Kazadi, you can now screen share and you can start your lecture.
Thank you. Okay. Fine. Oh, what's happening? Sorry.
It's okay. It's okay.
Something has happened.
You just need to run the slides once.
Okay, but I don't see them. Oh, here we are. Okay, perfect.
Yeah.
Okay, now how do I get rid of the pictures so that sorry, I can see your faces, so but they are over on my slides.
We can see your slide actually.
Yeah, but how can I remove?
Okay, can you just press the escape key and you'll get in? You'll get to see your own slides.
Okay.
You need to share again, please.
Okay. Okay. But I can see your faces, but on my slide. So I don't know how to get to remove them.
Actually, we can see your slide well, actually.
Okay. But I need to read them as well.
Yeah.
Okay, now. Okay, it's okay.
Is that what?
Thank you very much. Yeah, okay. It's okay. I can see something, but it doesn't matter. It's okay.
Okay.
I'm pleased to present to you the prevention of head injuries. As we all know, that's the cheapest way really to treat patients, is to prevent actually injuries. Because despite the progress we've made in this field, prevention remains still the best thing to do. You can see now a picture of a bear and a fish. As you know that in Canada, because you're standing in Canada, some times of the years, you know, the fish which are going against the direction of the rivers, and the bears, they know that, and they just sit and then eat that fish. So I saw this picture. It was very interesting. So I wrote for the fish which was just near the mouth, I said, that's too late. So if that fish was clever enough, it would have actually prevented by being on that side where you can prevent. What are the possible causes which are causing really head injuries? We need to know them and to understand them. And there are quite a number of them. First of all, particularly in third world countries, there is inadequate public transport systems. It means people are taking anything in order to move from point A to point B. And we have deficiencies in regulations. And when the regulations are there, are very difficult to implement. That's very important. That we see also even in developed countries. The poor maintenance of vehicles, that's also another thing which is linked to poor countries and the lack of resources. So people are using cars which are not really in good conditions. Other possible causes. There is this risk-taking behavior of the public. Usually people would say, oh, I'm going to pray, God will take care. They speed, they overtake, they drive under influence of alcohol, they don't wear helmet, they don't, they overload the vehicles, they don't respect the idea of putting the seat belt. And in their mind, they say, in any way, when it is your time, your hour to die, you'll die in any way. That's basically the kind of mentality you find in some people. And other possible cause is alcohol, excess speed, of course, we spoke about that, noise, sleeping while you are driving, and of course, drugs people are taking, which are genuine drugs they take because they are sick, but which can be actually dangerous when they are driving. Now, there have been, of course, attempts to try to find solutions because everybody realized that the solution wasn't to treat head injuries, it's to prevent head injuries. And there were plenty of rules which were put there, motorcycles helmet use, drunk, driving low. For example, in Belgium, when we are driving, you shouldn't drink more than 2 glasses of wine. Beyond that, it is, I mean, a problem. You can pay a fine. Seat belt low, and cellular phone prohibition, child car seat enforcement, and so on and so forth. As you can see, the list is huge. Speed control, and I can extend these lists, you know, necessarily. And you can see at the down there on my slide, I've written X, Y, Z. It means whatever law you put, people will manage actually to go around the law. So how do we try to do that? To make sure that people get the message. We know that when a human being has a clear knowledge and enough reasons, motivations about the why he or she is doing something, so this person will do it without any supervision. You see, for example, people who are doing advertising, whether it is a good advertising or bad advertising. Let me give you an example. Smoking, for example, it has been, you know, popular on young people because of advertising on the movies and the way the movies are done, the way publicity is done, and so on and so forth. And people automatically, they start now to smoke. Same thing for some drinks, how they're introduced in the public. So we can use that same method to make people understand the behavior when you drive, which can actually lead to head injury. So when you look at it, first of all, those are facts. We all know them. Head injury is extremely common. And yes, it is common, particularly in low-income countries. You see the figures from the United States. I'm not sure each country can give its own figures. But I think the most important thing to realize is that it affects young people between 15 and 24 years or over around 65 years. And you know that those are the people every nation needs to build the nation, to develop the economy, and to develop everything. Those are the people we need. And mostly, actually, among them, the vast majority are actually male because of their risk-taking behavior. So those are facts. Now you see that picture. It's a picture where you see those people who are on the back there, they pay less, of course, than the people who are inside the car. And if they are choosing to travel on that particular position, it's because they are economically challenged. And they feel that that's the best way to keep a bit of money. Okay. And one would say, oh, they are full. But I'm sure that if we were in the same position, we probably will do the same. They've been doing it every day, and it has been like something, you know, they have been doing, and it's sort of normal for them. You see these cars there. Now, when you see at the end there, you see that you'll see that there is a track where there are people who are sitting over vegetables. It means the driver is coming late in the evening in the city. That's happening in Harare, so that the police cannot see him. And he carries some passengers so that he can make a bit of pocket money. And you can imagine if this car has an accident and something will happen. Of course, people will actually overdose vegetables. And I was driving behind, and I took that picture and I showed it to my wife. And I've been saying that in several fora. And my wife said, oh, that's a very good picture. By the way, how did you take that picture? So I didn't realize that I was also having a behavior which was not safe. Here you can see a helmet following, you see how it is broken following an accident. This is, by the way, a nephew of mine. Fortunately, he had this helmet. Otherwise, you know, he would have died. Now, let's talk about speed and accidents. Speed is responsible for 30% of accidents. But people say, why? Okay. And those are also facts which was proven that severity of the accident increases with the speed. Let's say a mortality is multiplied by 20 at the speed of 80 kilometers per hour compared to a speed of 30 kilometers per hour. So it means somebody who is hit at that speed is likely to die compared to somebody who is hit at 30 kilometers per hour. And mortality of a pedestrian who is hit at 30 kilometers per hour is 5%. While if somebody is hit at 50%, it's actually 45%. At 80 kilometers, that's death. Now, why is speed something dangerous? We need to think about the braking distance. It means a vehicle in excellent condition. There is no rain, okay, and its drive is going on 50 kilometers per hour. It needs 14 meters because that's a reaction time from the driver, which is 1 second, and then plus 12 meters because the vehicle needs a bit of time to stop. The total is 26 meters. And those 26 meters, that's the distance where you do not have any control at all. And if you drive at 90 kilometers per hour, the distance, of course, increases to 64. Therefore, we understand very well, at 120 kilometers per hour, the distance is 102 kilometers. Oh, sorry, 134 kilometers at 140 kilometers per hour. As you can see, those are the distances where you don't have any control at all. At least it's very important to know that. Those are the things, facts, we take for granted, but we don't know, or we never told. I also learned that when I was preparing this topic. The other thing to know is that the higher the speed, the smaller the visual field. And of course, the difficulty to avoid an unexpected obstacle. Pedestrians, for example, when they drive, they are walking, they have a visual field of 180 degrees. But somebody who is driving, for example, 130 kilometers per hour, which is done basically regularly, the actual visual field is only 30 degrees, which is very, very small. So it means basically it's a tunnel kind of driving. According to European Transport Safety Council, by just decreasing the speed by 5 kilometers per hour, you can actually save a lot of lives. So it's very important to work on the speed. That's why they tried in France to try to reduce the speed, and you could see that actually they managed to save quite a lot of lives. The other things also, the recommendations are each car should keep at least 2 seconds between two cars because the distance is 60 meters, and that's the speed of 120 kilometers per hour. And of course, it's very important to drive slowly, particularly when visibility is reduced. And when it is raining or it is night hours. The other factors which are causing accidents is sleeping while driving. Remember that we all sleep when we are driving. The only difference is that the time we are sleeping is so short that we don't even realize, and we manage actually to control the vehicle. And the risk for accident is between 1300 and 1500. Of course, at the time we are digesting and we are keen actually to sleep. That's where Spanish, for example, they like to do what they call siesta because they know that that's the time really you are sleeping, you are tired, you've just eaten, so you need to relax a bit. As I said before, we all sleep when driving. And sleep increases significantly after we've been driving for more than 2 hours. And remember also something, because people are saying, well, when I feel that I'm going to sleep, I will stop. That's not true, because sleep comes without warning. Have you ever observed people? I mean, we've done it all. You are actually watching a movie, and the next thing, you wake up and you are seeing now the movie is finished, and you see out the names of actors and so on and so forth, and you don't know when you slept. That can happen even when we are driving. So, what are the factors which are actually making us even sleep? Likely to sleep is lack of sleep. That's very important, because somebody didn't sleep a day before. In African culture, for example, when there is a funeral, for example, people tend to go and sleep at the house of the dead or the person or the bereaved family, and then the following day they go, then they have the funeral. But during that night, nobody sleeps very well, because the people are crying, the people are singing, the people were praying, and therefore in the morning, people actually are actually half sleeping. And no wonder why, during that period, there are quite a number of accidents, and you'll hear that, oh, those people, they went to a funeral, and then on the way back, they had an accident. And the explanation is very simple in Africa. They will say, oh, that's normal. It's that the dead person didn't want to go alone, so he had to carry some other people. But the truth is, people didn't sleep very well, and therefore, while driving back, they slept while driving and then had an accident. This is very, very common. Not only that, people, when they are in the car going to a funeral, they really cry very loudly. That's the tradition in Africa and some other countries. And that noise is like loud music or people are crying, can actually cause an accident. The other reason is also when you have been awake for a long time. Somebody woke up very early, 4 o'clock in the morning, and has been driving that part of the night, and then during the day, you can have an accident that you can sleep very easily. Drug consumption. When we say drug, it's not necessarily cannabis or other things like that. There are also other drugs, which I'll give the list later on. The heat. In hot countries, the heat can be very, can make somebody sleep. And also, the other thing which is also very important is the sleeping passenger in the front seat is also dangerous, because it's got hypnotic effect, particularly when you are breathing on the same rhythm. You can actually sleep and carry on, and then you sleep as well. So those people who are sleeping, who like to sleep on the front seat passenger, they should go actually behind so that you avoid an accident. Well, how do you know then that you are going to sleep? Okay, I'll give you quite a number of clinical signs. Now, those clinical signs, you don't have to add them. Each sign is enough to say, that's enough, you best stop and sleep a bit before you continue to drive. When you see that you have difficulties to keep the head erect, that's already on its own very important. Repeated yawning on its own is very important. It's not the two of them together. No, each one is enough. Okay, and you have quite a number of other heaviness of eyelid, itching eyes, difficult to keep constant speed, difficulties to concentrate, lack of perception of road signs. It's very important, because you'll see somebody telling you, oh, have we already, passed, that city or that town or that monument? Okay, scratching one's eyes, touching one's chins, to rub one's nose, and so on. Those are signs that your sleeping time is imminent. And you don't have to wait for 3 of them or 4 of them. No, 1 is enough. So, what are the guidelines? It's important that to take light meal and drinking a lot of water when driving long distances, not beer, water. Sleeping passengers must go on the back seats. Stop and sleep for 20 to 30 minutes. It's so important. You lose only 20 to 30 minutes. At least you arrive where you are going. But if you keep on going, and have an accident, you won't even arrive to your destination. And avoid driving between 13 and 1500 hours, because that's the time people tend, to sleep easily. So, as I said, take your time, sleep well the night before you travel, avoid excess of noise. People are crying, as I said, during the funeral and so on. And when you feel sleeping, the danger are people who are taking coffee. And they say, oh, if I drink coffee, then I will wake up. No, that's not true. It's a lie. It's a lie. In fact, coffee will just delay or hide actually your clinical signs, which are telling you that you should go and sleep. So coffee becomes very dangerous. The best treatment is stop and sleep. Or if you have another person who is also a driver, just change drivers. That's the most important thing. Now, what about drugs and alcohol? As I told you before, in Belgium, when you drink more than 2 glasses of wine, you can have a fine actually. But somebody will say, come on, I just have 2 glasses of beer. What's the problem? What is wrong about it? Well, as I told you before, if you are driving at 90 kilometers per hour and you decide, because you see an obstacle, you decide to drive, you have 25 meters because that's 1 second reaction time, plus 39 meters where that's the inertia of the car before the car stops. Now, that's 1 second. But when you drink 1 cup of beer or 2, your reaction time actually increases. You don't actually now react in one second, now react in 2 seconds. So if now you add that factor, you'll see that the number of meters you require before actually you brake are actually longer than when we are not drunk. Some drugs also can cause movement incoordination. It's very important, or reduce concentration. And those are drugs we give to a lot of patients, like anti-epileptic, sometimes beta blockers, and so on and so forth. So it's very important to remember that. They reduce the reaction time. Hypnotic, like benzodiazepine, sedatives, and so on and so forth. There are quite a number of drugs which we prescribe every day. And it is important to warn patients and saying, you are taking those drugs, please don't drive, or get somebody to drive. Or when you're driving, reduce a lot your speed because you're just going into the shopping center or something like that. So patients should know that. Of course, no driving with alcohol or having drinking alcohol. And the patient must be warned, as I told you, regarding, and of course, those who are combining alcohol and drugs, that's a cocktail for disaster. Now, of course, the cars should be in perfect condition. That's unfortunately, we don't achieve that all the time in third world countries, because to have a car is already very expensive. To maintain the car is even extra expensive. People, they prefer to buy a sandwich than to go and change the brakes, or they go and buy the reconditioned one and then do all sorts of things, to continue to move around. Okay, and brake malfunctions and so on and so forth, and tires, balancing tires. Those are luxuries people have in Europe, and which we don't have in third world countries. So, in conclusion, I would say MVA causes a lot of misery, and they cause death or serious brain damage. It's got a huge amount of money for families and for the community. Prevention is much better than treatment. And for the beer and the fish, it's better actually to be down there to the water than near the mouth of a beer. Thank you very much.
Thank you so much, Dr. Kazari, for this presentation. In fact, it's very important to have these guidelines with us because obviously prevention is better than cure. I would like to introduce a few new panelists, and then we can go on to the interactive session. Dr. Raza Sabiri, can you please introduce yourself?
Okay. Just a second, I'm coming.
Hello, everybody.
Hello, Dr. Raza.
Hello, I'm Raza Sabiri. I'm very happy to stand here today. I'm a brain surgeon, member of American Association of Society, a member of Walter E. Dandy Neurosurgical Society. I live in London, but my nationality is from Afghanistan. I'm very happy to stand here today. I think it's a very good idea for sharing knowledge and help together for save a life. Thank you so much.
Thank you, Dr. Raza. Welcome. Dr. Abdul, can you hear us? Can you please introduce yourself? Hello, Dr. Abdul. Okay, there is some problem with the Dr. Romano Aden is he also with us? Can you please introduce? Dr. Romano, are you there?
Hello.
Hi.
Okay, there we go.
Hi. How are you?
Okay, could you? Oh.
Hi. Good morning. Good morning.
Hello. Good morning, Dr. Hello.
Hi, it is Dr. Bankolin Rodin. I'm a resident in neurosurgery.
Okay, welcome, Dr. Bankole.
How are you?
We are good. We are good. Could you please introduce yourself here?
I don't see. I don't know why my video work. I don't know why. So can you help me, please?
Oh, I think you need to check with your webcam or your camera, please. John, can you help him? Yeah, that's fine. Yeah, we can see you. Yeah.
Okay, but how can I do, please?
Yeah, we can see you. We can see you well. You can please go ahead and.
Okay, now you see me?
Yes, we see you. Yeah. Yes, Dr. Bangoli, we can see you. Can you please introduce yourself?
Okay.
Yeah.
Good morning, everybody. Good morning.
Good morning.
Okay. To listen Professor Kalangu for his introduction about care, and I believe that it is very important to work together to share more about prevention, because prevention is always and already better than when the trauma is be done. You can do nothing if the traumatism be high severe score. And I think that if you try to avoid accident, it's very better. So that is why it is very important to know all this prevention and share it our by said our parents and colleagues, and have to all persons have to know that it is very important to avoid all these things. To avoid the accident, it is very important. It's very, because now if you see, I know, and according to the literature review, 19% trauma brain trauma, it's come because the etiology, it is accident. the more common etiology is accident. So if we can do something, all neurosurgeons in the world in his site can try to promote prevention. It is very good. It's very good. It's very good. And I think it is my opinion.
Thank you. Thank you so much, Doctor. Thank you. Yeah. So yes, of course, it's very important to have a prevention rather than a treatment.
Yes.
Can we proceed with Dr. Christine Silva? She is with us from Brazil. Dr. Christian Silva. Yeah, he's with us from. Yeah. Can you please introduce yourself? Dr. Silva. Yeah, we cannot hear you. Can you please unmute and introduce yourself? Yeah.
Okay. Hello.
Yeah.
Are you hearing me?
Yes,
Hi.
we hear you.
We can hear you well. Yeah.
Okay. Good morning. I am a neurosurgical resident. I'm Cape Verdean, in fact, and I'm doing my residency in Brazil on behalf of the WFNS program of training young African neurosurgeons. And I'm very interested in this subject because neither here and in Cape Verde will be my reality. And as Dr. Kalangu was talking, we now have to be preoccupied not only with our assistance, but with the environment that those traumas are being involved. So most of them are due to the traffic accidents and the education and the spread of information to the people, to the population who are involved in that. It's so much important to avoid and work in prevention than spend a lot of cost. In most of the country and those that I am from, and here in Brazil, we struggle so much with the costs to those patients that came with so severe injuries, the lack of helmets, the non-conscious driving, and I'm so thrilled to be a part of this symposium and to know the guidelines and to. I think that's the way. It's spread information and instruct the population and work preventively to avoid those kind of traumatic injuries. Thank you for the opportunity.
Thank you. Dr. Elmer, can you introduce yourself? Okay, he's not here. Okay, Dr. Hitesh, can you please introduce yourself?
It's okay. We'll get better at this.
Yeah, because a lot of panelists are not able to. Okay,
Yeah.
so any questions, any comments for Dr. Kazadi's from all of the other panelists, maybe the speakers, anyone?
May I say a few words?
Yeah, sure, Dr. Tariq, please proceed. Yeah.
I think, as Kazadi pointed out, prevention is one of the most important aspects of neurotrauma care. We generally speak of neurotrauma care starting from pre-hospital care and then going into ER and ICU. No, I think it should start from prevention. And for the last year or so, the Neurotrauma Committee of the WFNS has made it one of its cornerstones to have a seminar on prevention of neurotrauma wherever we have a meeting of the Neurosurgical Society. We have seen that many organizations like the Think First International, with whom the Neurotrauma Committee now is collaborating, it has made a very big difference regarding prevention of different forms like helmets, seatbelts, etc. You can look at the history of Vietnam, Hanoi, where thousands of people were saved from injuries and deaths because they started wearing helmets. So I think it is really, really very important. And thank you to you all and Dr. Kazadi for bringing this forward again.
Thank you so much, Dr. Tariq. Dr. Parthiman, would you like to have some few comments on?
Yeah, it's a very nice symposium, and the talk given by Professor Kalangu was excellent. That shows the basic requirement in the developing countries, like in India has got a very chaotic traffic. It has a high-speed roads, but at the same time, every vehicle passes into the same high-speed road. We do experience this type of problems. We are trying to discipline ourselves. The first thing is, whatever I have seen, he has enumerated is more disciplining ourselves first before we get into the road. We always tell about the roads are not good, but the speed of the cars are increasing. It's very powerful. But the first thing is the discipline, self-discipline. The self-discipline will definitely reduce the head injuries quite a bit. Now, like Professor Tariq was telling about the WFNS programs of neurotrauma, quite a bit has to be done in the developing countries, particularly. India is a very, very big hub for head injury. We know there's a massive, massive head injury, and they are trying to put a lot of restrictions and the helmet as a compulsory in many states, more compulsory in now the state from where I'm coming. It's becoming as a routine rule. This apart from the basic treatment protocols. Like now in recent past in India, we started the helicopter transfers of patients. So this is one of the recent developments where it's more equaling towards the Western countries. It is from the basic from the discipline of the public to the highest technology where we can try to help the head injury patients. First thing is prevention. The first one is prevention, like Professor Kalangu said. It's a wonderful talk. Thank you. Thank you. Yeah.
Thank you so much, Dr. Parthiman. So now we head with your next talk. Let me introduce Dr. Parthiman to the panel. Professor Parthiman is a senior consultant neurosurgeon in Tamil Nadu, India. He is the board member of the Neurosurgical Society of India. He's also a member of the Spine Committee for the World Federation of Neurological Societies and a board member of the Asia Pacific Cervical Spine Society. Today, Dr. Parthiman will be talking about the procedure of cisternostomy and the Indian scenario associated with it. So, Dr. Parthiman, you can now share your screen. And
I will share it, and then I have to share my the presentation.
Yes, please.
Are you able to see my presentation? No?
Not yet.
Are you able to see now? No?
No, Dr. Parthiman, you need to click on the share screen option down on your screen, the green option.
Yeah, I have done that. Yeah, okay, right. There is something, share is coming here.
Yes.
Are you able to see now?
Yes, that's fine.
It's full screen or it's okay?
No, it's not full screen. You need to play it in the
yeah. Okay. Is that okay?
Yes, that's fine. That's perfect.
All right. Thank you, friends, and Professor Kalangu, Professor Tariq. Very nice to see all of you. And I have my residents there. Hitesh and Vaibhav is also there. I have asked my residents to join this program because this is going to be the future of neurosurgical exchange of views. Today I'm going to talk something about a little bit of subject and a little bit of what is happening in India. Cisternostomy is a term now is being commonly used in our country now. Particularly for the past 2 years, there is a very big hike in this procedure, and there has been a lot of topics, a lot of Congress discussing on this topic. In and out, and every neurotrauma meetings, we are discussing this particular subject. Before 2016, it was pretty quiet, but then calm. But then after 2016, there is a phenomenal change in the Indian subcontinent. We started talking more about this subject. Professor Aipcherian has done quite a bit of contribution towards the development of this procedure. I come from this part of India. You know, this is the southern part of India. The mark where you see is Coimbatore. From where I come, this is the hospital where I work. It's a very big hospital where we see quite a bit of head injury patients. We have 4 consultants neurosurgeon with teaching facilities for neurosurgery. So there is a very good post-operative and also ICU care systems, quite a bit of advancement in neurosurgical field in this. Now, when I discuss about cisternostomy, I always call this as the CS of drainage procedure to keep many people quiet and calm and composed. I make myself to call this as a CS of drainage procedure, cisternostomy. Now, we do know that it is a big challenge to reduce the ICP. We do the medical management, ventilatory support, and then we depend on our surgical procedures to reduce the intracranial pressure in a severe head injury patient. The first and foremost in the surgical management is that evacuation of the hematomas, any type of hematomas, EDH or SDH, ICH, or there are contusions. Apart from this, then we have a diffuse brain swelling, that we have the famous decompressive craniectomy and dural opening. But of that, what next is about CS of release procedures. We all know that CS of need to be let out to reduce the ICP. It's a very common sense, and as neurosurgeons, we all know about it. Now, I'm sorry, you can see that these are the CS of drainage procedures. One is in the sulcal subarachnoid space. If you open the sulcus, you do get CS of coming out. This I usually call it as golf course holes. You may make like in a golf course, you have a lot of holes there. Like that, now when you open the sulci, multiple levels, and you find the CS coming out in a moderate head injury patients, and then later on you find the brain is pretty soft. The next is the Sylvian cistern. We try to open the Sylvian cistern whenever we as neurosurgeons are familiar with that. Then subsequently comes the basal cisterns. The basal cisternostomy is the most now we are going to discuss about it. And EVD, we all know it is a long olden days procedure. We all do external ventricular drainage. But if you look at all these procedures, they are not new procedures. They are already being done by our elders, our seniors, from Dandy to Cushing, and everyone have done these procedures. Now, why this basal cisternostomy is getting into so importance is because, this is what the hypothesis of 100 years. We all know that the CSF is produced in the ventricles and slowly drain out of the ventricles through the 4th ventricle and comes out the subarachnoid spaces and then get drained at the superior sagittal sinus through the arachnoid villi. This is what we have been taught. But subsequently, there was more understanding about the Virchow-Robinson spaces. Now, this Virchow-Robinson space is nothing but an indwelling area where the gyrus is the near to the gyruses, you have spaces where you have arteries which is getting into arterioles and getting into the Virchow-Robinson space. Now, you can see there are so many articles written on the new look at the CSF movement and the new concepts of cerebrospinal fluid physiology and the development of hydrocephalus. So these papers are all talk about where the CSF is produced. Is it only produced in the ventricles or it produced somewhere else? But as per the understanding goes on, it is being now established that there is something happening. The CSF enters the brain along the cortical pile arteries and proceed to the parenchyma through a facilitated pathway called Virchow-Robinson space. So this is being well demonstrated, and I was discussing with Hira, and we got some of the pictures, some of demonstrating the very beautiful experimental and clinical evidences to say that the fluid is going through the Virchow-Robinson space into the parenchyma. So this part is very important to understand, and this type of experimental studies have concluded, with MRI imaging and subsequent histopathological examination clearly revealed there's a shift of the CSF from the cisterns into and around the brain parenchyma. So something is happening at this level when a CSF get locked up. So this is the basics of the rationale for releasing the CSF from the cisterns which are locked after an head injury, because subarachnoid hemorrhage is the commonest hemorrhage and that clogs all the CSF pathway in the subarachnoid region. So wherever the arachnoid and the base is full of flooded with the blood, I'll show you in some of my pictures now. And it obstructs these from these regions at the Virchow-Robin space, which causes the problems. This is one. So in traumatic subarachnoid hemorrhages, it increases the intracisternal pressure due to subarachnoid hemorrhage. It perturbs the lymphatic pathway, causing shift of the cisternal CSF into the brain. And that contributes the brain swelling. So this is the hypothesis now is going on. And cisternostomy aims to reverse this shift and to reduce the ICP. Now, this is what is the hypothesis. This is the very classical lymphatic pathway. You can see this picture everywhere. In you Google it, you get this picture, very beautiful picture. You can see one side, then artery comes. Another side, you can see the veins are there. And there is a fluid is going across. The fluid is lymphatic fluid is going across. So what happens in an injury, this is disturbed. So the elevated pressure gradient in the cisterns causes a decrease in this lymphatic removal of the fluid, and thus also causes the shift of the fluid from the cisterns into the extracellular space at the Virchow-Robin space. So Virchow-Robin space is a continuation of the cisterns. It is the cisterns, that is the basal cisterns, through which the Virchow-Robin spaces are going as small. From the ocean, you can see the backwaters which are getting into many places. Like in India, if you ask me, it is in Alleppey. If you ask me about in Bangladesh, you can see everywhere. You can see seepage. So it seeps into the country. Now, this is the sequelae, which I already told. I need not repeat it. And this is about the cerebral edema. We know about it. So, how to remove this fluid? How to remove the CSF from the basal cisterns? This is a very beautiful picture. You can see here. When you retract the frontal or the temporal base, and you can reach the optic nerve, and you can see the Lilliquist membrane there. Are you able to see the Lilliquist membrane in the subarachnoid spaces? It's a very beautiful picture which shows the Lilliquist membrane that divides between the supratentorial and infratentorial, the subarachnoid spaces. So Lilliquist membrane, actually it forms the roof of the prepontine system. Now the CSF is there everywhere, above and also below. Our aim is that to reduce the CSF completely, not only from the supratentorial region, but also from the infratentorial region. After seeing this picture, I would like to go to this. Please watch this operation. Here is the brain. You can see this is the brain part. This is the assistant end. This is the frontal lobe. Now you can see that. This is the acute brain, and then it is after ventilation. You can see the optic nerve here. This is interoptic space. You can see so much of CSF is coming. I hope that all of you are experiencing it. Now you can see that the arachnoid is removed. This is the optic nerve. This is the carotid artery. You give a very low suction, and operating between the optic nerve and the carotid artery, you find the Lilliquist membrane deep inside and open the Lilliquist membrane gently. This needs microsurgical technique. Basically, head injury is becoming now microsurgery. Microsurgical technique is essential to, you can see this leaf of this membrane slowly getting teased out, and a copious amount of saline is placed to wash out the subarachnoid hemorrhage. You can see one more layer of Lilliquist there. Yeah,
This is one more layer of the lilicus. Open it. When you open, we can find the prepontine cistern, and also we can see the basilar artery. So now once we get the CSF drain out slowly, when this procedure being done, you find the brain is soft, becoming soft over a period of time. You just have to maintain a little bit patience during trauma surgery. And here you can see here, this optic nerve, this is interoptic space. So much of CSF keeps coming out. What we need is a patience a little bit. And we have certain policies in my unit in our hospital. I'll let you know about it later. And now you can see this is on the upper side of the screen. This carotid artery, optic nerve. This is the area. Now I place one drain here. This goes at the prepontine cistern, and this drain drains out the CSF in the post-operative period. Now to show you a few cases, I can show you. Are you able to see the cases? Here is a patient came with the GCS5, the bifrontal contusion. This is severe edema. GCS5 is very obvious. I don't need to tell about you can see the cisterns are not seeing properly. This is post-operative. Case 1, this is the first post-operative after a decompressive craniotomy and cisternostomy. Now you can see there is a definitely reduction in edema. You can also see some of the cisterns start coming out. And this is on the 8th day of the post-operative, 8th day of post-op. Find very amazingly, you can see a lot of CSF in the subgaleal space. So that means the CSF is tracking down through these places where we have done the cisternostomy. It tracks down, comes to the subgaleal space. This obviously shows that the CSF shifts from a high pressure zone to a low pressure zone. And this patient was discharged with a Glasgow Coma scale of 11 after about a month. Now, this is another patient with a bifrontal hemorrhagic contusion, came with a GCS of 7 and 15. On the first, the moment we come, we usually intubate the patient, ventilate, and our follow-up CT scan showed this much of rebleed. You can see the huge, large rebleed. And so there was no pupillary change, and patient was on ventilator support. We took the patient for surgery. The clot was removed. And here we did the basal cisternostomy after a decompression. And we also replaced the bone flop. Let's look at this. We replaced the bone flop in this case. This is the first postoperative picture. And this picture, and you can see after a few days, on the 14th day, postoperative picture is very beautiful. Good decompression is done. And this patient was discharged after 45 days with a GCS of 10. So there is a shift of CSF from the basal cisterns to subgaleal. In this case also we can appreciate that. We usually keep the drain for about 3 to 4 days. Sometimes even I have done for 5 days. I've kept the CSF, the drainage even up to 5 days. This is the third patient. Yes, this is a left frontal contusion, ASDH with mass effect. You can see the prepontine cisterns are completely filled and there is a mass effect. This patient, this is a pictorial of this patient. You can see the brain is very, very hot looking. The left optic nerve, and we have opened the cisterns. And after opening the cisterns, we are able to see the complete, the optic nerve, the chiasm, the carotid artery. Now you can see the better picture with microsurgical pictures. You can see the left carotid artery, the chiasm, lateral to the left carotid artery. In this case, lateral to the carotid artery, we went to the lilicus membrane. I approached both frontal and also through the pterion approach to the basal cisterns, and whichever way is familiar to me, and to the case-to-case basis, I change my positions. And here we have gone left to the carotid artery. The lilicus membrane is reached in the open. Now, this is the surgical technique. Whatever I said was about the basal cisternostomy, but we do have patients in the malignant brain edema, you cannot do anything. You can see that in some cases where you find difficult to close even the scalp. Such a large edema we could not do in some of the very, very malignant edemas when you take straight away from surgery. And you can see in the down the picture, you can see another case with significant edema in spite of cisternostomy and CSF drainage. So we have to wait and watch in these type of cases. So this is another case you can see here. Before the decompressive cranectomy, there is a severe swelling of the brain overall, and after the cisternostomy, there is a lax brain. You can see in the middle, and the middle picture, you can see the arrow showing the drain. And later on, in these type of cases, when the brain goes down, I always put back the bone flap here. As you see, a bone flap has been replaced. This is another case. You can see the brain before the cisternostomy, and this is after the cisternostomy. The brain is bit lax. So this shows that the CSF letting out does help in many ways. Now we have studied about 29 cases, though we have done more cases now. The 29 cases we studied methodically for 6 months period, and I will show you the results here. Yeah, if you see in the bottom side, I could able to see the mild injuries and moderate injuries, they do very well. But in the severe head injuries, you can see there's 70% favorable outcome. Favorable GOAs, unfavorable about 30% in these cases of 29 cases. There's a very interesting thing which I noted in this case. I'll come to the next slide. Whenever we replace the bones, we found a better GOAs. That is 82% of patients did well when the bone flops were replaced. Then when the bone flops were not replaced, that is after cisternostomy, you let the brain to be open without being closed with the bone. So if you compare these things, you see there's a better GOAS in those cases where the bone flap were replaced, and unfavorable is more in the places where the bone flops were not replaced. As far as I discussed with my junior colleagues because they were discussing about the chi-square and the data collections, though they are not significant, but definitely there is a change. This is the slide which shows the overall picture, and we had you can see about the same study which I have showed now. On the lower side, if you see the severe head injury patients, both look the same. However, in overall, if you look, this is the total picture where we compare the cisternostomy and we compare with the decompressive cranectomy patients. Now you can see the red marked area. The favorable outcome is 79%. 79% with cisternostomy, and in decompressive cranectomy it is 69%, which is slightly less. Unfavorable is definitely more in only in decompressive cranectomy, unfavorable less in cisternostomy. If you ask me, the numbers are very small. Yes, I agree, but then it gives some idea about it, idea about what we are dealing at present. Now, here also you can see my overall surgical results. As I told you, in cisternostomy, I'm able to get a better results in severe head injury patients. 70% have become better. But look at in decompressive craniotomy, only 46.2% has become better. So these are some of the small points that shows there is a favorable that if you do a cisternostomy or you do a CS of lateral procedure better and better, your results are going to become better and better. So this slides shows some of my results, and I also had an opportunity to get some of the slides from my colleague Roy. Roy's study also shows something like 46.2% favorable outcome. In decompression, he had only 35.5. So there is some sort of a 10 to 50% difference is always there. You can look at that rounded area which he has shown. There is about 10 patients. The numbers are small only, but they all are showing some sort of indication that we are moving towards a different era of our neurotrauma care. Now, even in the neuromonitoring data, if we look at that, ICP is significantly lower in 48 hours after cystostomy. There will be considerably less use of osmotherapy, and CSF is drained about 120 ml per day. In my experience also the same, sometimes 90, sometimes 120, sometimes it's more. So I continue to drain it as number of days as possible, 3, 4, 5 sometimes. So I'm happy that more CSF comes out. I'm pretty happy about it. So this is about Roy's study. And then I think Ayub Cherian will come and talk about it, I hope. I think that he may be talking about, he has got a massive number of cases. Probably I think he can, probably he has the largest number in the world now. Probably he can give a better idea. Finally, what I feel is that the basal cystostomy, it definitely drains the CSF instantly. And backshift of the CSF from the VRS, thus causes some sort of a intrabrain pressure, and thus prevent further interstitial fluid accumulation. So that shows the results in clinically. So we need to prove this, and it is proving clinically we are able to see this. Clinically, we are able to see a better and better results. There's an excellent drainage of CSF, and hence the brain becomes very lax during the surgery. Continuous CSF shift to subgaleal space is a very interesting point which I wanted to tell you, because that shows the CSF like to move from a high pressure zone to low pressure zone. So if there is going to be higher pressure in the VRS and it is going to be less pressure in the basal system, the CSF will shift back. The CSF will come back from VRS into the basal systems, then it goes to the subgaleal space. And then in return, definitely reduces the intraparenchymal shift of the fluid. Craniotomy bone flap replacement is possible, and we have to be very patient to assess that. It can be done very nicely. Basal cystostomy does not change the primary injury. This is my personal view. It is not going to change the primary injury, but it will definitely prevent the secondary injury. It may not be a standalone treatment for brain edema, which is a quote in the color region I'm telling about it. But then over a period of time, it may change. All our views may change. Sometimes we do not know. CSF, let alone, may change the whole thing, and we may be going towards a new era of neurotrauma care. I want to tell, before I close with one thing. We all neurosurgeons, we all know about, and Professor Tariq may remember, Professor Kalangu may remember, Professor Tariq may remember, in those days, we were talking about trigeminal neuralgia. Am I correct? In trigeminal neuralgia, everyone says that the vascular compression, if there is a vascular compression, there is a pain. You remove it. This is what Peter Janetta told us. But what A.B.T. Adams said? A.B.T. Adams said, no. It's a foolish argument. It is an epileptic process in the brainstem that produces the pain. But whatever the discussion went on in the hypothesis, what is happening today? Today, we are all doing microvascular decompression. Irrespective of anything, we open posterior fossa and we do microvascular decompression. And we get a very good result in trigeminal neuralgia. And I have a feeling that even in this cystostomy, basal cystostomy is a CSF-related procedure, definitely for sure. The hypothesis, some people believe, some people don't believe. But however, the results are showing towards a favor in cystostomy. Thank you very much for your kind hearing. Thank you very much. Thank you. Hira, thank you.
Thank you. Thank you so much, Dr. Parthiman. Dr. Parthiman, can you please stop your screen share so that I can proceed to the panelists?
Yep.
Thank you. Okay, we have with us Dr. Bang from China. And would he like to just say a few words, because he is also part of the Cisternostomy group in the world. So Dr. Wang, would you like to talk about any comments?
Oh, yeah, Wang is there?
Yeah, he's there, but he's mute. He's there from the operating room. Dr. Wang, can you unmute and talk, please?
Oh, yeah, Dr. Wang, how are you?
Hello, Dr. Wang, can you hear us? Yes. Dr. Wang, can you hear us?
Hello.
Hello, Dr. Wang. Can you hear us? Yes, we can hear you.
Yeah, Dr. Wang, nice to see you.
He dropped off.
Nice to see you.
Okay.
Dr. Wang, would you like to say something about cisternostomy?
And now, my cisternostomy, I have bought a device about cisternostomy monitor. And use such as monitor PRX, and that is pressure reactivity index at CPP. At this so many parameters. I use PRX monitor.
Oh yeah.
Yeah. So these days I have bought a device at the monitor PRX after cystotomy. And now I collect some data.
Okay, what is that about PRX, your monitors? It's about for the ICP monitors, or?
Pressure reactivity index, PRX.
Okay.
This is the new monitor device. For 3 days. I bought this device for 3 days. And select some data about PRX.
And I think that's about the post-operative.
This is new.
Yes.
Yes, it's good.
Yes. And we have numbers from China, right?
I can set some data. This is my second, and now I have second patient data about PRX. At this evening, today is my duty. Since I have brain trauma surgery next hours.
Oh, great! Yeah, I have a feeling that you have a large number of head injuries. I see you operating quite every day.
Every 4 days I have duty.
All right.
Every
good.
4 days.
Very nice. Yeah.
There's a lot of brain trauma. In my neuro ICU, there are 70 beds. 70 beds. Neuro intensive care unit.
Yeah, very nice.
Yeah.
Because I watch your operating the videos, because I show a lot of my operating videos. I see the similarity about the operative technique. The faster you reach the optic nerve and the carotid artery and start dissecting both between and lateral quickly, the CSF, we can reach the iliacus very fast and the CSF get trained well. Because we were discussing about the surgical technique last time. I hope you remember. We were thinking more about the surgical technique, how to reach the basal cisterns. The approach is quite down at the some people were suggesting even whether they have to do a fronto-orbitozygomatic resection for reaching the basal cistern. I do not know what is your opinion, because some of the questions were asked whether you need to remove to the base to reach the cisterns, because I don't do it. I just go with the subfrontal arterial approach. I'm very comfortable. How about you?
Sorry, in my operation room, there's the signal was not good. Yeah.
Okay.
Yeah. So and now more and more Chinese doctors learn about cystostomy. Because Dr. Yuha is in Henan province, and he wanted to let the Henan previous doctor do this surgery. And now they have do some patients about neurotrauma and brain aneurysm.
I see. Yeah.
May I say a few words?
Yes, sure, Dr. Tariq. Please.
It's understandable that when you release CSF, the pressure goes down. That's the basis of all this, and something very important. We do it all the time when we are doing brain tumors to try and CP angle tumors or pituitary tumors, etc. What I also understand that it is not easy. You need to be very good at your microsurgical techniques, and you need to be very good with your microscope and very good, and you should have trained a lot to be able to do these sort of things independently. So my recommendations, suggestion, request, I see a lot of young neurosurgeons here in the audience, that I think it's first best to be trained in microsurgical techniques, to be very good at it before one starts attempting this new novel procedure, which may be found to be very good at some stage. But I think it's important not to be doing it if you're not really trained properly in going to the base of the skull and using the microscope. I think that's very important.
Agreed. Yeah, agreed, Dr. Tariq, and wonderful thing. Yeah. Now, in fact, that I have, I think, two of my my postgraduates are here. I think they are in this. They are listening. These guys are now keep seeing my operating technique, and they are used to this microsurgery, microscope adjustments. Sometimes, if I turn the other side, these guys retract and they go to the optic nerve. So far, they are getting used. As you write, you pointed out very clearly that you need a good training, first microsurgical training. Now, what we do is that two of my postgraduates are here, and if you ask them, they will tell you. And slowly we will request them and allow them to retract the subfrontal lobe slowly, and go to the optic nerve slowly, and then come to the optic nerve and dissect the arachnoid. And then later on, then they will say, "Sir, I'm okay, I'm here." Right? Then I come back. So, as you rightly know, like a father is taking the child with a finger, like you take the juniors along with it and train them. And maybe here you can ask one of my students to talk. I think Vaibhav is there, Hitesh is there. As Professor Tariq is telling from the experience, that microsurgical training is the basic. Now, it has to be mastered. Whether with the microscope, or if you don't have a microscope, then you need to do with the loop, not with the naked eye. We have to do with the magnifying loop. And these things, I think seniors like us, we may have to train our juniors in this aspect. I agree with you, Professor Tariq. Excellent, yeah. Hira.
Dr. Parthiman. Dr. Webb, would you like to add on to this? You're his resident. Will you please add on to this?
Vaibhav?
Can you hear me?
Yeah, we can hear you. Please hear.
Okay. So first of all, I would I want to say that it's a privilege to work with Parthiman sir. He has been like a godfather to us. I am a third year resident right now, posted under Parthiman sir, and it's been 2.5 years that I've been assisting him in all his, his surgeries. So we see a great difference when we compare our results to other surgeons, and when we discuss the same things with other institute neurosurgeons, that what is the difference in the outcome. So I really feel that cisternostomy helps in all the patients to decrease the intracranial pressure, as sir has already told everything in detail. And we are having a great experience with sir in the management of head injuries and learning.
Thank you so much, Dr. Weber. Dr. Ahmed is also with us. He has been one of the fellows of Professor Cherian. Would you like to talk about something? related to this, Dr. Ahmed?
Hello, hi everyone.
Hi.
As Dr. previously said, Cisternostomy has good results, but you have, if you're not well trained about the procedure, and if you have a bad operation, the results will be bad, no matter how the concept is good. So you must be trained, and you have a good idea about the concept and the microsurgical techniques before you do these operations. And that's what I have.
Thank you so much, Dr. Ahmed. Dr. Bankole had something to say. Please, Dr. Bankole. Dr. Bankole, we cannot hear you. Can you unmute, please?
And then?
Yes, fine.
Okay. Thank you, Professor Parthiman. It is very good and excellent presentation. I'm a resident in neurosurgery. So I have a question for you, please. I want to know, because in my department, when we have trauma and we just perform decompressive craniectomy. And I do one study, one prospective study about all cases we perform, and I see I come to conclude that is not good. We have not a good result because we just perform decompressive craniotomy. We don't perform cisternostomy or ventricular cisternostomy. And I want to know now that if that is the guidelines to perform both of cisternostomy and decompressive craniotomy, or we just perform only cisternostomy before perform Doppler transcranial Doppler transcranial to know if you have high pressure of CSF.
Okay.
And then because I don't understand how to perform cisternostomy. And your ventricular cisternostomy, did you perform it like ventricular cisternostomy in obstructive hydrocephalic case to perform it just behind, like we perform shunt of external shunt?
Okay, I will tell you. Now.
Okay.
Okay, I understand what you are telling about. See, we all know that to reduce the ICP, that we do a large craniotomy, right? Craniectomy. Okay? Okay, that craniectomy is very large. It starts from the pterion, the frontal, and then we make a large one, right?
Parietal occipital, yes.
Yeah, you make it nicely, big one, right?
Yes, and remove pterion.
Yeah, actually, frontal to pterion. Once you remove this, you will have edematous brain. You can definitely edematous brain. Now, I will tell you a few ideas to do, because if you see my my presentation, I have made golf course holes. First, usually, what I do is I try to open the sulci over the surface.
Okay.
Over the surface of the brain. Multiple levels I open at the sulcus and keep it, let small CS2 to come out. While it is coming out, while it is coming, it may help you, but may not. I'm not very sure 100%, but it will help you to moderately and slowly. And then, see, majority of my surgeries, please understand, very important point is that it is like your aneurysm surgery. You keep the maxillary area superiorly, top, so that the brain falls back.
Okay.
That is very important point. Otherwise, you will be uncomfortable to retract the frontal base. It will be uncomfortable for you to retract to the frontal base. So the maxilla should be at the highest, and they should fall back, so that your cut should be very, very low down. You have to see the base. Your retractor should go to the base. Now the shortest area is the pterion.
Yes, we can. Yes.
The longest is this place, that is in the frontal. So you can always come to the pterion and you reach the cisterns very easily medial to the Sylvian cistern. You come to the optic nerve very closely. So the distance is very, very small. Now, if you can't retract your brain, if you're lucky enough to have a frontal hemorrhagic contusion, remove the frontal hemorrhagic contusion. Yes, you remove it, you will reach through the, the lesser being of sphenoid, just follow it, you will reach the anterior clinoid process gently. And that's a place, just gently retract. The moment you see the optic nerve, you're done. That's all. So this is an important tip for you. I understand why you are stuck. See, for the next time when you do the head injury management, that's what I thought my PGs will tell. So the head should not be tilted up. The vertex should not be tilted up. It should be like this.
Position before perform surgery.
Yes, absolutely. Next time you do it and you tell me next time, you can communicate with me personally. If you do that, your surgery is very, very easy. Many people ask me the same question, sir, how will you? Because if there is a flexion, the brain falls away from you. You try to retract. And so you go away, you jump on the patient's head. It's not possible. So the head should be nicely positioned so that it's like a skull base. Yes, for a skull base surgery. How do an aneurysm surgery? Like the same position. So trauma case also should be planned in such a way that you do an elective frontocranial base surgery for aneurysm. Am I correct? Okay?
Yes. Yes.
This is the surgical tip for you. Yep.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Parthiman. We have a comment from Dr. Kazari. Could you please, Dr. Kazari, could you please ask your question?
Yes. Okay. Thank you very much. Congratulations, Dr. Parthiman, for this excellent and didactic talk. It's very good, and there were nice pictures. And I liked also the comment from Tariq about the fact that you need training. I love the way you're explaining to Dr. Bankole how to do the operation. It's like explaining to me how to fly an aeroplane from my desk. I think the best thing is to invite Dr. Bankole to come to your place and see by yourself. That's how I learned as well. I went to see Dr. Cherian and see him doing it. And it looks so simple, but yet difficult. And as Dr. Tariq was saying, you need training. That's very, very important. Not only training, you need the right instruments. Because don't improvise. Because if you improvise, you are going to fail. This is the reason why, at the beginning, this technique was very, very criticized by many people.
Yes.
But when you talk to them, it's because they didn't have the technique. Of course, it's like you are not a pilot. Of course, you have a lot of crash of the aeroplane. It's exactly the same thing. Absolutely. So it's very important to know the technique through somebody else, not in the books. You can actually read the books and see videos and so on, but go on the field and learn. That's one. Two, have the appropriate instruments, because this is a kind of surgery which doesn't forgive the lack of instrumentation. You need few instruments, but you need them. So maybe it could be interesting for maybe if we have time or in the future, or if you can maybe send it on the web, saying those are the basic instruments you need and the kind of suctions you need.
Yeah.
One of my questions I want to ask is, when you put the drain, at which height do you put the bag? Is it at the level of the head? Is it above, or is it below?
Okay. See, very honestly speaking, that I like to keep it slightly lower, because I want the CS to come down. I want the CS to drain. I don't want the CS to stay there. So I always tell my students, keep the drain down. Keep the drain down, let it flow. Because CSF is just like a water which is coming from a dam, flows down. It is coming from a hill, it has to flow down. So for that, we need to make a pathway. Now, if you keep it straight, then what is the point? So you keep it low. Let the CSF drain out. And Bankole, I welcome you. You can come to my place. You're welcome. We'll show you, no problem. I'll help you now. Professor Kalangu. So I always keep the CSF down. No
down. Okay, perfect.
Down.
Thank you very much.
Yeah.
It's very important to let know youngsters that you see that it has to drain.
Yeah, yes. And another thing is that because now there are so many drain tubes here and there, I usually ask them to mark it in a color, in a different color. Otherwise, it will out.
Exactly.
We have a lot of problems. So nowadays, my nurses know what is cisternostomy drain.
Yes.
It was not known many years ago. Now they say which is subgaleal drain, which is cisternostomy drain, which are other drains. So you have to be very specific in those things.
Exactly.
We train our residents in such a way, so they take care, and the nurses also take care accordingly. Yep.
Thank you very much.
Thank you.
Thank you very much. Thank you very much, Professor Parthiman. Thank you very much. I hope I will see you next time.
Sure.
Thank you.
Yeah,
thank you, Dr. Parthiban, and thank you for your talk. We had a good discussion and interaction. Any more questions and comments before we proceed with Dr. Tariq Khan?
Okay.
Okay, so let me introduce Professor Tariq Khan. Professor Tariq Khan is the Professor of Neurosurgery and Dean of Northwest School of Medicine, Peshawar, Pakistan. He's the Chairman of the Neurotraumatology Committee for the World Federation of Neurological Societies. Can I please invite Dr. Tariq Khan to talk about the civilian cranial missile injuries? Professor Tariq, please share your screen and start the talk. Thank you.
So, hi, thank you, Hera. Thank you, John, for inviting me. This is a very good forum, I think, for all of us to learn, and some very interesting topics, very hot topics which are being discussed. Now, tell me, how do I share the screen?
You'll see you find a green option which says share down the screen.
Yes.
Just click on that and go to your presentation from PowerPoint.
Okay.
Yeah.
So can you see that now?
No, not yet.
Oh. Gee. So I press that green icon.
Yeah.
And then what happens?
And then it asks you to share your screen.
It doesn't. Does it?
You'll have to click on share again. It will give you an option of screen. It will select screen and then gives you an option to share again.
That's the rightmost place with the arrow on it, green arrow, right? The other one?
Yeah, the other one. It says screen.
No.
Okay, the option for share screen is in the below. You click on that, and then on your leftmost you see an option which says screen, and then it's written share. So you need to share that, and that will share your screen.
No, I see. Hold on. I'm very sorry. I think I need to. So live, then there's a recording, then there's speaker view.
There will be a green box.
Green button down there, down.
Are we there?
Yes, if you scroll your cursor, yes, now it's fine. Yeah, you're sharing it.
We're there, right?
Yes, we can see that. Yes, you just need to go to the play option.
Yeah.
Yes.
Click it.
Yes.
Okay.
We got that. Thank you.
So thank you very much. So I'm going to talk about civilian cranial missile injuries. This is my hospital in Peshawar. As we all know, cranial firearm and blast injuries have a very high morbidity and mortality rate. The civilian cranial firearm injuries and blast injuries, unfortunately, are becoming more common everywhere, even now in the Western world, as we can see all the time on the TV. There are different types of cranial missile injuries. You have low velocity injuries, and you have high velocity injuries, you have blast injuries, and you have other types of injuries like spent bullets, etc. Now, the high velocity injuries are very dangerous. These are from rifled barrels with a muzzle velocity of greater than 2200 feet per second with a kinetic energy of nearly 2500. And the most important aspects of this high velocity injury are that they cause a cavitation effect because of yawing effect. Now, yawing effect is something, if you can see this diagram here, that the wound channel from a high velocity bullet from an AK-47, so it first follows a straight line which creates the phase 1 of the bullet, which is a narrow channel, and then it tumbles and it keeps on tumbling, and that is called the yawing effect. And that causes a very big cavity which can be 25 times the diameter of the bullet. And then the bullet carries on more or less in a straight line to produce another narrow channel. This all depends on the distance traveled and how big the mass is in which the bullet enters. So you might not see a yawing effect in a small area, and you might see a yawing effect in a bigger area. So the bigger area, the bigger the cavitation effect, which causes a lot of damage. The low velocity are handguns, and they have a low muzzle velocity of 750 to 1400 feet per second. Now, the incidence, the formula for body surface area exposed in combat trauma is more as about 15% to the head and neck, and majority of them are to the from the head and neck. Majority are to the main skull, and less than 15% to the occipital region. In the military areas, because they are wearing helmets and body armor, so there's much less. But in the civilian thing, they're about 15%. Although the vault offers much more surface area to injury in the whole cranium, but those are the patients likely to survive. The posterior fossa and base of skull, although are less commonly seen, but the mortality from those injuries is very high. So the factors which determine the extent of the injury depend on the nature of the projectile, meaning that whether it's a low velocity or high velocity, and the point of entry and angle where it enters. So the low velocity would have low kinetic injury. It would have minimal shock waves, and its entry point would be usually the weaker areas like in the temporal fossa, etc., or the supraorbital region of the skull. And the high velocity would have high kinetic injury and would cause shock waves. So if you can see this, it illustrates, depending on what type of bullet it is, high velocity, low velocity, and will it traverse through the brain and end up on the other side, or will it get stopped depending on how high the velocity is of this bullet. Then the blast injuries have a very different pattern because they have the shock waves in it. There's a temporary vacuum effect there. There is stretching, deformation, which leads to further effects. And then, of course, there are the penetrating missiles and blasts, depending on what type of blast they are, whether they are IEDs or whether they are suicide blasts, which would have ball bearings, etc., in them. So it would be, the important factors from that would be the penetration, the tissue density, the fragmentation of the material, the detonation, the shape of the charge, whether it is an IED or what type of it is, the overpressure from the blast, depending on how big the blast is, the combustion effect and incendiary effect. So if you look at this figure here, in the center is the place where the blast has occurred, and that will show that you will have the heat effects and all the effects of this. The more distance you are away from the blast, the less the injuries. So if you are far away from it, depending on what far is according to the to the nature of the blast. You would have fragmentation. Nearer, you would have an impact injury also. If you are even nearer, you would have an overpressure effect. And if you are the nearest to it, you will have the heat and combustion effect as well. So depends on how far or how near you are to the blast injury. So basically the management again is initially the simple management is A, B, C, D, E. And once you have done your A, B, C, D, that is that you have made sure that the mean arterial pressure is okay and ICP, the airway oxygenation, and to make sure that the arterial pressure is around 70 millimeter. Once you have done all that, then you again reassess the Glasgow Coma scale after resuscitation. Once you have resuscitated the patient and you know that the patient is stable, then you look for doing plain x-rays, do a CT scan brain, and it's important to do bony windows and 3D pictures in the CT scan so you can see the different areas which are damaged. And very important, if you feel and if you suspect that there is a vascular injury, then you would also look for a CT angiogram of the brain. Initial management of a firearm injury or blast injury would be similar to all other brain injuries, giving bolus of mannitols, giving saline. But we also must know that if there has been a blast injury and if the skull is fractured or it is the cranium is opened up, patient may have already decompressed themselves because of the fracturing and opening of the skull, and you may not need even to give mannitol or saline in that situation. Antibiotics. Compared to the ordinary road traffic accidents, there's a very high incidence of infection due to entry of foreign bodies, hair, bone fragments, clothing, metal, etc. And in the pre-antibiotic era, there was more than 60% mortality because of infection, and it has come down to 4 to 11% since the advent of antibiotics, and much less in the civilian setup. It was found that Staph aureus was the most common pathogen, and broad-spectrum cephalosporin third generation with metronidazole and also HD tetanus is very important. You can see this paper which suggests it's on infection neurosurgery from the British Society for Antimicrobial Therapy, and they recommended cephalosporins and flagyl. Seizures, they are much more common in closed traumatic brain injuries. The question is whether you should treat with anticonvulsants or wait for a seizure. So it has been shown that the more severe the injury, the penetrating brain injury, according to the GUS, the higher the risk of development of post-traumatic epilepsy. And 30 to 50% of patients will develop seizures. And out of them, 10% will appear in the first 7 days, 80% in the first 2 years, and about 18% may not have seizures until 5 or more years. And it has been recommended that anticonvulsant therapy should be instituted at least in the first week of a penetrating brain injury. Frankly, personally speaking, I put them all on anticonvulsant therapy because if they develop a seizure in the first week or so, it can worsen the prognosis, especially in areas where you may not be ventilating the patients or the nursing supervision may not be as good as in many other countries. So it is my recommendation is they should be put on anticonvulsant therapy, and I usually put them on it for at least 3 months. The definitive treatment is, of course, to do a craniotomy, make a flap around the entry and the exit wounds, remove all the devitalized tissue, removal of the accessible bone and bullet fragments. Now, there is no need to be going in, digging deep into the brain, trying to remove all the bullet fragments or all the penetrating fragments, because that may cause more damage than doing good. The importance is to do copious irrigation with saline so that all debris can be washed out, whichever can be washed out. Never go fishing for the bullet or never go looking for all the fragments. I think that's very important. And you must explain to the relatives beforehand that the idea is that to try and clean the wound and not that you are going to, because the relatives are very concerned about the bullet and they ask questions that why have you not removed the bullet and can you remove the bullet? I think it's very important to explain to them beforehand because later on, they might cause problems. Hemostasis, and very important, and closure of dura. In the developing countries, you have got pericranium, gallia, fascia lata, and of course, in the developed countries or people who can afford, we have the artificial dura to that. And then adequate scalp closure. So it has to be washed, clean, remove all the debris as much as possible, not all of them. Wash it clean and close the dura. It's very important. Many a times we have seen that people may not close the dura, just wash it and close the scalp. And later on, because of infection and the brain matter coming out, and then it becomes very difficult to reoperate. So it's always best to do it well the first time. You may not at times be able to close it. It can happen, of course, but you must try your best to do as much as possible. Post-operatively, careful observation, airway, tracheostomy, humidified oxygen, ventilation, unicatheter. I personally would ventilate them for 48 hours, mostly depending on the severity of the injury, but mostly, and then gradually wean them off. I think that is very helpful in reducing the brain edema. And later on, if required, do a tracheostomy. That. Later stages, physiotherapy, DVT care, nutrition. I think rehabilitation is something which is most often neglected and is the most important part. Now, this goes for all brain injuries, whether it's penetrating or other types of brain injuries. You might have read this paper where they compared the Glasgow outcome score between a center in India and in the United States following a decompressive craniectomies for trauma, and they found that in the first, when they were going home, or the first 3 months, I've forgotten now, the outcome was the same with ICP monitoring, without ICP monitoring, but because they did not have rehabilitation through the 2 years, results showed a big difference in a better outcome for the patients in the United States compared to India, because there was no rehabilitation in our region, unfortunately. I think that's very important. Rehab centers are very important. There was a very nice paper from Aga Khan University in Karachi, which was, I think, published in World Neurosurgery Journal, that to train the family members in rehabilitation so that they can, when they go home, they're able to look after the different needs of the patient. I think the GUS outcome can be misleading because you have post-traumatic syndromes, you have social problems, mood swings, headaches. You need psychologists and psychiatrists also involved in management later on. I'll just give you a little thing about our region. This is Pakistan and Afghanistan. And this is our culture, that we are having firings at all occasions when we are happy, especially if we win a match from India. We are firing in the air and many people die, sadly, unfortunately. Little children have guns. When we are in fight, people have guns. So we did a little study to determine the prognostic indicators of mortality in civilian gunshot wounds. And we used a retrospective analysis, and we had 98 patients or from 213 to 217. And we looked at the demographics, arrival GCS, vitals, pupillary status, CT score, outcome, LOS, and mostly male patients. Medium arrival was GCS 7. And the blast injuries also, we did a little study. Again, we had 18 patients, and we looked at the favorable and unfavorable outcomes, and we compared them with the Rotterdam score and many other parameters. And the conclusion was that there's more in males as a result of assault, and majority were received with low GCS and poor pupillary responses. And we found that, of course, arrival GCS and pupillary status were strong predictors of mortality. And the Rotterdam score, as you all know, it's a good score, can also help in predicting outcome. And timely ICP targeted intensive management and anatomical restoration was the prime importance in improving outcome. But as Kazadi said earlier on in his talk, that most important thing is prevention is better than cure. And this we started in the early 1990s, and we are doing a lot of work. School teachers and college teachers are running these programs with children to try and educate them so that they can go home and educate their elders about prevention of neurotrauma. Many people in India are also doing a lot of work. In Jaipur, our friend is doing a lot of work, and I'm sure in other cities in the world they're doing that. And I would like to invite all of you to the International Conference on Recent Advances in Neurotraumatology, which is being held in Peshawar, Pakistan from 7th to 10th March 2019. As you know, it's an official a conference of the World Federation of Neurosurgical Societies. We're offering 50 academic scholarships for young neurosurgeons with the best papers. That is, those we are giving them free registration and free accommodation. The website is here. Anybody who's interested, we would like to welcome them to Peshawar in March. Thank you very much. Thank you.
Thank you so much, Dr. Tariq. Dr. Tariq, can you please stop the screen share?
Yeah. Let me see. Okay.
Thank you, Dr. Tariq. That was a great talk. Do we have any questions or comments from the panel? Would anyone want to talk about anything? Pardon? Yeah, please.
Please, Professor.
Yes, please.
Yeah, it's very interesting, very nice talk on this civilian injuries, because it's quite amazing to see the civilian injuries. And in India, it is slightly lesser, but not very common. But then in the northern part of India, it is pretty common. You're firing on the air, then accidentally you fire. And then the accidental fire also occurs in police force in India. We see many people have severe head injuries in accidental firing. And I have a feeling that this is more common in the United States now. And in the US, it is becoming more dangerous. This is what I feel, that more we say in this region, in our region, that becomes a society, cultural society for United States. That's what my personal feeling is. Though in Asian part, I do not know how many numbers. As Professor has, Tariq has given about 98 cases in about 5 years' time. It's a very large number. But as you rightly pointed out, we had a few experience when I was a student. If I get back to that, I can't call that as a civilian injury, but it does happen in Tamil Nadu. We used to receive patients from Sri Lanka during that ethnic war was going on. So that time we saw, as you said, a lot of bullet injuries in the head, and it was very tough to define that. We were not having an idea about whether the bullet to be removed the wound. As you said, the wound was clean and everything was done, but finding the bullet at one place is very difficult. And the big argument was whether the bullet need to be removed. It was a very biggest argument, and I agree with you. We cannot chase the bullet because it changed the places. It changed the place. Then you may need to have an on-table navigation or on-table X-ray guidance or whichever guidance we need. Because I've seen surgeons chasing from one area to another area, but then we can't. So we do not know. We really need to remove those bullets at all because having it has done enough of damage. It's truly thoroughly an important subject because though we see very rarely, but we should know what we should do on that occasion. Very nice discussion, Professor Tariq. Thank you.
Thank you.
Thank you. Thank you so much, Dr. Parthiman. We have some new panelists with us. Do we have Sarah with us anymore? Okay, no, she's gone. Slaven, can you please introduce yourself, Slaven? Hello, Slaven. Okay, so I think we don't have any more questions or comments from the panel. Do we have any questions?
Especially
yes, please. Yes, please.
Hi again, Professor. Congratulate to your talk. I want to ask a question. I am living in Turkey, border of the Syria. I approximately do cranial surgical operations related to gun missile trauma, more than 300. I am doing some different things not related to literatures because especially frontal sinus penetrating missile trauma, I'm cauterized mucosa, and after that, I'm mostly using vancomycin embedded bioabsorbable sponge in the frontal sinus, and after that, I'm covering it with, Gallial flaps. What do you think about this procedure? Is it in use, or do you do something like that? Thank you.
Thank you. Yes, I know. Unfortunately, that region at the moment is having a lot of trouble, and you're seeing a lot of injuries there. I think typically, if you have a frontal sinus injury, it is best, like when you open the frontal sinus, you should pneumatize it. You should remove all the mucosa, clean it, and that's the best thing to do. And you can even use bone wax or Gale or whatever to cover that. Yes, that is pretty acceptable what you're doing, and we have done it many times. I think that's the right thing to do because that is a very big place for source of infection.
Especially when you think related to vancomycin embedded absorbable sponge, do you use this kind of procedures or you don't just cauterize the mucosa?
No, we cauterize, remove the mucosa. We have used vancomycin powder in many places, many times. Yes, you can do that.
Thank you, Professor. Thank you.
Thank you, Dr. Tariq.
Hi.
Yes, Dr. Bangula, please.
Please, I have one question for Professor Parthiman. Please, Professor Parthiman, did you use your technique about ventricular cisternostomy when you have case about stroke ischemia? Stroke?
No.
No. Okay.
No.
Okay. Thank you. Okay. Thank you, Professor Tariq, of your talk. Very nice talk. Congratulations.
Thank you very much.
Yeah, thank you, Professor Tariq. So I guess Professor Aib Cherian is on his way. Actually, he's in a conference in Belfast from where he'll be talking. So he's just on his way to get an internet connection. As soon as he joins, he'll be here. So till then, if you would like to have any more interactive session and any videos Professor Tariq or Professor Parthiman would like to share, you can take your time, please.
If anybody is interested to see one more video on cisternostomy, if you want one more video on cisternostomy.
I think, yeah, you can go for that.
Yes.
Sure, we have.
Yeah, let me see.
Thank you so much.
That's a good idea.
I think you have a big following here anyway on cisternostomies.
Okay. I have to see now how to get back. I don't know how to get back now. Yeah. I think I'm able to.
So Dr. Tariq, did you?
Yeah. Are you able to see this?
No, not yet. Not yet.
Not able to
Sorry,
see.
you were saying?
Yes, yes, we can see this now.
Able to see that?
Yes.
Okay, it's a short video, and you can just see the technique. I think Bankole, Dr. Bankole, please have a look at this video.
I'm here. Yes, I see this. I see that. Yes.
It's an edited. You can see the contusion here. The
Yes.
base here, the contusion is there.
Big contusion.
Yeah, this is the frontal base. Frontal base. You can see the bone cut here.
Yes.
Cut, and this side is the pterion. The dura is reflected back. This is the frontal lobe, frontal lobe, right? Now you can see that. Remove the clot. So you go to the base. You're able to see. It's optic nerve.
Okay, you open optic nerve.
Yes, you have to go to the optic nerve.
Okay.
Now you see the arachnoids, you tease it out slowly, gently. This is medial to the optic nerve.
Yes.
See these arachnoid layers, tease it out gently.
Okay.
And cut them gently, gently up. See so much of CSF falling?
Yes.
It's a pituitary stalk. You can see deeper down, it's a pituitary stalk here.
Yes, yes, here.
You can see that nicely. Yeah.
Yes, yes, I see that. I see that.
That's a chiasm. That's a chiasm here. That's a chiasm. Now you come lateral to the optic nerve.
Okay.
Arachnoid, gently teasing.
You have carotid.
Oh, sorry, something. Yeah, sorry. I redo it.
Okay.
You can see that again. And
yes. Contusion.
Yeah.
Okay, you retract frontal lobe.
Good, good. Yeah, you're following. That's good. You tell. That's nice. Yeah. You tell. Yeah. Yeah.
Okay.
Yeah. You learn that way. Yeah, you tell that. Yes, correct. There are arachnoid.
Yes, subarachnoid plane.
Yes, yes. Gently dissected.
Yes.
That you can see the instruments. These instruments.
Like
Professor Kalangu was asking about the instruments, micro instruments, dissectors, micro scissors. A good microscope.
Yes.
Obvious amount of saline. You can see the pituitary stalk there. Now I come. This is anteroclinical process here.
Yes.
This is lateral to the optic nerve. Lateral to the optic nerve. Yeah, I'm cutting that arachnoid there.
Yes.
Cutting the arachnoid. Cutting the arachnoid. You can see gently, huh?
Of course.
Now you can see the carotid artery.
Yes. We have a carotid artery.
Yeah. Now you can see the gap between between the optic nerve and the carotid artery. You can see the Lilliquist membrane.
Okay, just okay.
Done. You will do the next case. Yeah. Yeah. Now you see that the basilar artery. You can see the posterior prepontine system.
Yes.
Right.
I see that. Okay. Yes. You have nerve here.
Yeah. So keep on putting saline. Keep on putting saline.
Okay.
I give one more important technical aspect here. Ventilate nicely before you take up the patient for surgery. Ventilate nicely, then you take up for the surgery. You can see the chiasm. You can see this. See the perforators. See the perforators. This is the pituitary stalk. You can see every arachnoid. You can open it out slowly, gently.
Gently, yes. Of course,
Very
gently.
very gently. You can see that? Now you can see
Yes,
the
I
cancer
see.
better.
Yes, yes,
Opposite optic now. Opposite optic now.
yes, yes.
It
Okay,
is.
now you do basal cisternostomy.
Yeah, and now you look at this. Yeah, yeah, very nice. See,
Yes, I see. I see that.
now you cannot do in every patient. You cannot do like this. Some patients you can do it, and moderate edema is very fine. Now, why I ask you to ventilate the patients? You must have a very good ICU, and if you have a very good ICU, intubate, ventilate the patient, and don't be in a hurry to operate. Ventilate the patient nicely. Use anti-edema measures, and then the position. Now if you watch this technique, in none of the time the brain falls forward. The brain always keeps posteriorly because the neck is very much tilted and the maxilla is the highest point.
Okay. Okay.
Thank you.
Okay.
Thank you. Thank you.
Thank you very much. Thank you very much.
Thank you. Mira.
I hope I will come maybe for one workshop to with you. I hope I will come to one workshop with you.
Yeah, sure,
if
sure.
you organize one workshop about it.
Yeah, we can
It's
do it.
very,
No problem.
Okay. Thank you very much.
Yeah. We'll do that. Yes. Yeah.
Thank you. Thank you, Dr. Parthiman. We have some new panelists. Dr. MBA, can you please introduce yourself? Hello, Dr. MBA. Dr. Mukhtar Khan, can you introduce? Okay, seems. Hello, Dr. MBA, can you introduce yourself? Hi. Hi, you're muted. Can you please unmute? Yes, please.
Right. My name is Dr. Mbara. I just came in when Dr. Parthiman was talking, and I did enjoy his talk about cisternostomy. I'm a neurosurgery resident in Zimbabwe with Professor Kalangu.
Very nice. Yeah. Good. I think, see, the more videos you see, it's better. It's my personal view is that the more videos, and if you're interested, I will talk to Hira. Maybe next time we can use more videos. When we repeatedly see the videos, we get an idea, right? You know, the whole problem is only the technique, and once you start doing it, see, I can see one of my postgraduate has come in. Prahalad has also come. They all these boys they do it because they keep seeing me doing it. Now the moment I take my hands off, they try to do it slowly, gently retract the brain, slightly retract and reach the optic nerve. Once you reach the optic nerve, naturally you try to dissect. I think Professor Tariq wants to say something.
Yes.
May I am sorry to interrupt, but please. Yes, you can see as many videos as you like, but please, until you are there and hands-on, do not even try to attempt this thing. I'm requesting. By the way, Cherian has promised that he's going to do a workshop, cadaveric workshop in Peshawar in March, on the 7th of March, on Cisternostomy. So let's hope he'll do it. I think it's very, I'm not somebody who's against this, please, but what I'm trying to say that it is a difficult procedure. It is not an easy procedure. So let's not look at nice videos and say, oh, this is easy. Let me get in there and let's do that. You can cause more harm than good. I'm sorry to be, but it's best to be cautious.
Yes.
To that. Thank you.
I agree. Yeah, I agree. It should be very cautious. See, as he said, what he's trying to say is that reaching at the carotid and optic nerve region must be very careful. I wanted to emphasize one important point. As I said, I would in one of my patients, I saw a small aneurysm. Believe me that there was an unruptured aneurysm was there. I was telling my postgraduate student. Look at that, so you cannot be, as I said, that you cannot just like reach the basal system. But if you have an incidental aneurysm, it was very, very shallow one. It is not a very, it was not having a neck, more of a bulbous one. And we didn't do that, anything. We just put a muscle patch over there and came back. As he rightly pointed out, that you need a hands-on microsurgical training, and then slowly get into the picture. That's what I also feel it here. Well, definitely, I think I've tried to make it to Peshawar, and it should be a very good meeting. Yeah, I think the way it looks. Last ICRAN, I was not able to come. Yeah.
Look forward to that.
Thank you.
I wanted a few ideas related to this subject, especially for young colleagues. You must always avoid from continuous retraction of brain. I'm sure that Professor Tariq and Professor the other professor will join my idea, because if you do continuous retraction, you must be sure that you will have brain contusion.
Absolutely.
I want to add this point.
Yeah. Absolutely, Professor Baran Foley, and I agree with you. But if you look at all my videos, we don't use any permanent retractors. Lila retractor, we don't use it there, and most of the thing is only with hand retractor. Then after, you can see that in the video also, there is no retractor there, both in the first one and also in the second one. So you reach there, you suck, and then you come out. You reach there, you suck, and then come out. So gentle. So most of my patients, we don't put any permanent retractors. It's a wonderful, it's an important point what he makes us, because the moment you put a permanent retractor, the edematous brain will bulge on both sides of the retractor edge. And that will cause more problem than what we intend to do. We like to do better, but then we will be doing more damage. And so cotton patties, a lot of cotton patties with the retraction, mild retraction, intermittent. If you can go through my videos, you can see all those videos will be like that only. There won't be any permanent retractors. Yep.
Thank you, Dr. Parthiman. We have a similar question from Dr. Silva.
Yes. Hello. Can you hear me?
Yeah, Dr. Silva.
Yes. It's a very interesting topic, and I am very interested on that. And as I before, I've seen the videos, and I've seen you. It's gentle and smooth management, but what I see and what I have in mind, that's why it's just seemed to be very distant to me, because it's we do with massive trauma, brain injury, and very complex injuries, and the brain is so the edema is so important, and the brain is so how can I say, so the parenchyma is so friable that any movement less than gentle will become more damage, like contusions. And in that case that you show, you have a contusion, and then you drain the contusion, and then you could access to the anterior fossa and open the cisterns. But the majority of the cases, I think maybe that is not possible. So I understand you said the position and the gravity will help you with less retraction, as we can say that. But what I see is in the majority of the case, I think we will not be able to do that because of the conditions. We are in a situation that the trauma probably happened a few hours before the surgery. So, and the question that I want to put to you is that when you came to the final point to let craniectomy or to put back the bone flap, still the retraction, when you came to the point that I will put the flap back or I will leave it without the flap, bone flap.
Okay, thank you. Yeah. See, I tell you that I have certain principles the way I work. I don't take the patient immediately the moment the patient reach the hospital. Now, our intensive care system is very, very good. So we intubate the patient, give the ventilatory support, hyperventilate properly, give enough of mannitol, right? The mannitol, sometimes 3% saline, ventilation. Now, if we look at that, and immediately I do not take up the patient for surgery. Carefully, in my unit, we always do 2 scans in subsequent time. If the neurological status is same, then we like to do the second scan in about 4 hours time, and you can see there's a lot of change. Now, you saw in my second case, within about 2 hours time, there was a bleed, right? In the first, the moment it comes, you do a scan, you have a picture. The same picture is not going to be there in about 3 hours time or 6 hours time or 4 hours time. Many of us, we try to, the so-called for the first hour of head injury. Last time I was in a conference where there was a big thought about the first hour. Is it really first hour? The first hour happens from the time of injury, and by the time the patient reach us, it's a different hours. We get the patients at different hours without ventilation, without support. But if the patient was lucky enough to get into a good hospital where a good intubation done, then he's very lucky by the time he reaches a tertiary care to us. So what I do is that I ventilate the patient well. Now, when I ventilate and give mannitol and then take up the patient for surgery, majority of my surgeries I was able to do the cisternostomy. But if the brain edema is very, very large, very, very, very bad, you saw that in one of my slides I showed, you open it, the brain just comes out. In those cases, obviously you cannot do cisternostomy. We have to tell very clearly, it is not possible, very difficult. You have to do the basal, drilling of the lesser wings, then you go up and down, then you try to do, sometimes if there is an ischemic changes in the brain which is going on so acutely, you hardly find the CSO coming out. So you need the pulsation of the brain for the CSO to come out. That is the one thing which gives a prognostication. The moment if the CSF is not moving out, when I open the cisterns, I know that this patient is not going to survive. The brain is very turgid. In those conditions, I don't think that we can help the patient much. But however, you asked your point, I make it very clear that you try this ventilation first and then take up give some time for the ventilation and then take it up and then tell me after about 6 months time how you start working on head injury patients. Well, what happened is that the moment the patient comes in a very, very bad shape to us. We do not know. I've seen few patients with a thoracic injury. We do not know. We just intubate. There's a huge pneumocephalus sitting over there. And whatever you do, a brain relaxation, and on the table, it bulges out. And I've seen that many times, anesthetists say, oh my God, we have a thoracic injury, we have to put the ICD. The moment you put the ICD, everything changes. We have done in one case in the operative theater. You put the ICD, then the brain is changing. Oh my God. So, as far as the cisternostomy is concerned, we cannot do it in all patients. But in many patients, you can try. You will say now it is very difficult, but over a period of time, with your experience, we will definitely do more cases. It is only a learning technique. It is going to be smooth and soft, and it will take its own learning curve. And the other point about replacing the bone flap. Now, you watch some of my slides. You show that the moment I see a gap between the dura and the brain surface, I always put back the bone. Nothing happens. In fact, all the complications, the so-called, we claim the side effects of the decompressive craniotomy, where the brain bulges even after a good decompressive craniotomy, you can see the brain is bulging out of the dural edge in the postoperative, second day, third day. But this will never happen if you put back the bone. So your CSF will be drained meticulously over a period of time because of your 3-point insistence, number one. Number two, you are keeping the bone there. The brain is also in the compartment and the CSO disc comes out. It's amazing to note. You saw in my patients, majority of the patients I try to put the bone back. If I'm not putting the bone back, that means that I doubt. In initial cases, I usually remove the bones. I don't like to. I was a little bit worried, but later on I start placing it. It's fine. So now I'm replacing the bone more often than earlier. So it is a curve. For everyone, we will enjoy the curve. You too will see that after about maybe 6 months or 1 year, you will see that. Yeah.
Yes, Dr. Brown. Yeah.
I mostly prefer high energetic cranial trauma. If I open the dura, or if I do operate the patient, I mostly prefer to do large craniotomy. I think you must avoid from small craniotomy because Professor Parthiman says that brain can bulge over the craniotomy range or borders. Yeah. You must keep in this idea every time in your mind whenever you operate the trauma patient.
Yep. Large cranial, that's excellent. Yeah, the craniotomy, I think, should be pretty large. So that, the smaller the craniotomy, actually the brain fungus is very high. It just bulges out. Then it is difficult for you to retract anything. But if you do it very large craniotomy with a good, the frontal and the temporal base, it is very ideal. So you must focus on a large craniotomy with the frontal, orbit, and also the temporal up to the zygoma. I think that should be the aim. Then cisternostomy becomes more easier. Yeah, Hiram.
Yes. Any more questions, comments? Okay, we have some new panelists. Slaven, can you please introduce yourself?
Yes, hello. My name is Slaven Gojkovic. I'm a medical student from Zagreb, Croatia. Thank you.
Thank you, Slaven. Welcome. Dr. Ahmed Adil. Hi, Dr. Ahmed, you're muted. You need to unmute, please. Dr. Ahmed, we cannot hear you. Can you unmute, please? Yes, please.
Okay. It's a good chance to share this. I am very happy to share you on this conference. But really, in Egypt, we don't do cisternostomy, and even this is the first time for me to hear about it. I practice in neurosurgery in Egypt for 5 years, and here in Saudi Arabia for 5 years also. But all consultants I worked with them only do decompressive craniectomy. They don't do cisternostomy. So I am keen to know more about it, and I will search through the internet to see what's going on regarding this cisternostomy. Thank you so much.
Thank you, Dr. Ahmed. Dr. Kugini, can you please introduce yourself? You're muted. You please need to unmute, please. Dr. Kugini, we cannot hear you. Can you unmute, please?
Yes. Now the connection returned back. So now you are hearing me?
Yeah. I'm talking to Dr. Giovanni. Can you please unmute? I think he's just in the car. He's traveling.
Yeah, I think he has a smartphone. So
yeah, he's using a smartphone. Yeah. So I think we just Dr. Aip is here. He's joining us. So he's just about to come. He's got the internet connection now. So we just wait for a few moments until he's back. Just give me a few moments, please.
I'd like to say something, Hira, regarding Ahmed's comment about learning about cisternostomy. I'll send a link. I'll put a link on the chat room of a lot of Ipe's talks about cisternostomy. Okay, Ahmed? Okay. And
thank
anyone
you.
else that wants to see references about cisternostomy, I'm going to post the link on the web. I think Giovanni's talking now.
Hi, I'm Dr. Cugini from Italy. I'm a residency in Germany, in Stuttgart. We have no experience with cisternostomy. We do only the open craniotomy, but no cisternostomy. And for me, it's very interesting to look at the application, cisternostomy and the compressive craniotomy.
I'm here.
Yeah, the problem is when and which patients and for example, old patients or the it is possible always the cisternotomy to do, for example, for old patients, or the
No.
only the compressive craniotomy.
Dr. Parthiman.
Oh yeah, we, Dr. Giovanni, we just were discussing about that, and in most of the cases, yes, you can do cisternostomy, but in some patients it is very difficult because of very severe brain edema, progressive brain edema. Sometimes it is very difficult. It's more of a technical challenge, so you may have to do a very large craniotomy with a very good basal exposure, then cisternostomy is possible. It is very clear from many of the experts that cisternostomy cannot be done in all patients, but in majority you can do it. It will take some time for it to do. Basically, you have to see this as a series of letter procedure, and once we think of that way, it's easy. Like I think you came very late in the symposia. We showed about how we open the series of cisterns at various places, including over the surface, sylvian, and then you go to the basal cistern. So each area you can open the CSF out. So the more CSF drains out, the brain becomes better if it is not primarily injured. This is more of the cisternostomy will help you definitely to stop the secondary brain injury. So for you to say, for me to say your question is that cisternostomies can be done in majority of the patients, but not in all patients. Yeah.
Okay, thank you, Dr. Parthiman. So we have Dr. Ipe sharing with us. Yes, he's the next speaker. Professor Ipe is the director of Noble Institute of Neurosciences at the Noble Medical College in Viratnagar, Nepal. He's the member of the WFNS Anatomy Committee and the in charge of ACNS educational activities. He's joining us from Belfast at the moment. He's in a conference there. And thank you so much, Dr. Ipe. It's yours now.
Hi, I just finished. It's so good to see you, Parthiman, Hira, John, and everybody.
Hi.
I just finished morning to afternoon dissection on Dollings and Kawase, so in Belfast. I was leading the dissection, and I had to run off a bit early so that I could come talk to you guys on cisternostomy.
Yeah.
But after Parthiman has given his talk, I don't think I have much to say. But I'll just discuss a few points that has been, coming into my mind over the last few months. So, is Tariq Khan also there?
Yeah, he's there.
Yes, I'm here. Hi,
Hey, Tariq. Excuse me, Tariq. I didn't have my lunch, so I'm just having a biscuit.
Yeah, carry on. We'll allow that.
That's okay. This is an informal chat.
So,
Yeah, we can hear you. We can hear you. I can hear you. Correct. Yes.
Now, we have a lot of young colleagues here who's asking us, what is cisternostomy? Why should we do cisternostomy? What are the indications? Is it possible in every case? And how does it differ from decompressive? Is it possible that you are able to do decompressive one day and then shift to decompressive the other? Shift to cisternostomy the other day. These are the usual questions that has been asked to me in the last. In the last 10 years, questions have changed a lot because we've gone from a position where people could not believe us to a position where people started believing us, but they believed that it is a technically difficult procedure. So from the perspective of questions, I want to talk today. So it's got to be an interactive session where Parthiman, if Wang is present, maybe Wang, Tariq, everybody has to pitch in. And then we got to see how do we take the best step forward. When I met this time, I met the Cambridge group as well as everybody else in Ikran in Naples. I realized one thing that, there's no point of us sitting and fighting over cisternostomy is best, decompressive hemicraniectomy is best, or conservative management is best. No, there's absolutely no point. The point is to take trauma surgery forward, the care of trauma forward. If conservative is better, then we should stick with it. If decompressive is better in some areas, we should try to see in which areas is it better. And if cisternostomy is better, then we should adopt that as a standard. We cannot give an excuse as consultants are not coming. Can you give this excuse in an aneurysm? Can you give this excuse in a tumor? So you cannot give this excuse in trauma too. And trauma is not something which is less important than any other surgery. It is neurosurgery, and it is not supposed to be meant for any young trainee to learn on trauma. No. This was done because this habit was started because we thought that big surgeries doesn't yield results in trauma, but that's not the case. So one thing Parthiman does is he keeps the patients for a day in an ICU where the patients are stabilized, and then they take up with microsurgery, they take up for surgery. Maybe that's a good thing because the brain, hypoxia, ischemia, all these things are taken care of. And then when you take up, maybe it's a better thing. It's a better way of doing it. Wang tells me about the Lund protocol, hypernatremia, and so on and so forth. Maybe that's a good thing too. So if there is ischemia, then maybe we should not put the bone flap back. So that is decompressive. So there are many facets of all these things which can help us. Now, how does cisternostomy help you? When you have an acute trauma, especially a subdural or a brain swelling in a pediatric population, we realize that if we can get into the base of the brain and then open the cisterns, we realize that the brain swelling goes down. And not only for trauma, for aneurysms which are grade 5 or grade 4, very bad aneurysms. For ICH, to do a Sylvian fissure dissection, you first open the cisterns, you go subfrontal and open the cisterns. The Sylvian dissection is much more easy and peaceful. So for severe head trauma, which has brain swelling acute subarachnoid to open the cistern is a way which can improve outcome. It is something that me, Professor Parthiman, Wang, and many other people all over the world has shown that opening cisterns in an acute phase in trauma brings down the brain swelling. So how does it affect the prognosis? Number one, what are you actually doing in decompressive? You know, if you take a 13 centimeter flap in decompressive, you are allowing about 120 ml of brain to herniate out through that flap. You can calculate this, and then you will figure that you are allowing about 130 to 120 to 130 ml of brain to herniate out through this flap. And because the convexity may not be so eloquent as to save life, you get away with it. But instead of that, you let out that 130 ml of fluid which has gone into the brain. You don't need to do it. That is the whole, in India we say funda. That's the whole trick of cisternostomy. It is based on CSF shift edema. I read papers from the Cambridge group saying that it's highly speculative. Well, CSF shift edema has been proven, but you could say it is speculative because when we started, we didn't have any evidence. Right now, evidence is building. But every new thing is speculative. You cannot get proof for everything in the beginning. But when it's working, you know, as I'm a surgeon, I'm not a theoretical physicist. I didn't first hypothesize and then start the surgery. I did the surgery. I found out that it's working. And that is when I started thinking, why does it start working? Why does it work? So it's the other way around. So we're not theoretical physicists, we are surgeons. So this thing in severe head injury, it works. I will vouch to that, and so does many good surgeons like Parthiman, Wang, and many others do. Why does it work? It's probably because of shift edema. Is it the only solution? No, it's not the only solution. How can it be improved? You have to accept the tenets from various other management, maybe the Lunt protocol, maybe the conservative therapy in some cases, maybe facets of decompressive in cases where there is ischemia, and many more. So this is the way to improve it. And it is not to say that cisternostomy is the supreme thing on earth for trauma surgery. It is just something which will contribute to trauma surgery, which is the biggest problem on earth for neurosurgery. So that is what I would say today. And I would like Parthiban, Tariq, and the rest of the people to comment on or ask questions on what I said just now.
Thank you, Professor Cherian. Yes, Professor Tariq, please.
Yes, I totally agree in something with Aib regarding that there's been a big shift from the time when we all would say, what are you talking about, Aib? We don't believe what you're saying. Today, as I've been saying earlier on with Parthiman, that I think it's very important that people should know what they're doing before they embark on this particular procedure. So it's become more of that don't do it at all, or we don't believe it, is more is that yes, one should try every technique which can help a traumatic brain injury. We have, you know, if you take the number of in neurosurgery, 60% is neurotrauma. So it is a very, very important part of neurosurgery to, as Ibe says, to hand it over to people who have just started training is unfair, not the right thing to do. We must take our youngsters along and train them in different techniques and to see whichever thing is going to be helpful. As you know, in Cambridge, we had this discussion, and in Naples, we had this big discussion as well. And this discussion will continue, but it's less of fighting now and more of positive discussion on how is it helping and how should it help. And I think in Peshawar, hopefully, IPE is going to do a workshop as well, and maybe there'll be more discussion on this. And I think there's a need of the hour to have a multi-center trial on this thing as well, to see whether, which is producing better results. And I think that would also help slowly improve the controversy. We also know that decompressive cranectomies are still controversial. There was a stage when everybody was removing the bone flap. It was right, left, and center. And then now, recently, we are saying that we're not sure it may be helping, but we are creating more, patients in vegetative state. So there is a pendulum which swings back and forth. And I think it is always good to try good ideas to see if that would help, but on the basis of scientific proof. Thanks.
Yeah, absolutely, because this discussion is going on and it will continue for a long time. That's not a problem at all. My personal feeling is that DC, decompressive cranectomy, there is no level 3 proof that it is really beneficial. Though there is a benefit to a marginal level, but it is not the only thing. Here, letting out the CSF. If somebody don't like the word basal cisternostomy, I put this way. I was telling I'm just letting out the CSF. I let out the CSF from anywhere. If it may be on the surface, or Sigmoid cistern or basal cistern. But why basal cistern? Because it is the biggest dam. That's a dam. That's a dam is holding this whole amount of CSF. And this dam, when it swells, it pushes the CSF into the Virchow-Robin space, and then the hypothesis comes. The problem in many of our scientists, many of our colleagues are to accept the hypothesis. Now, that is why I kept comparing this. I was just comparing this with trigeminal neuralgia. I think Hira, I discussed with you also, and with Dr. Ibe, and I discussed many times. I've seen Professor Peter Janetta honking on this point. Whatever there is a compression, then there is a root injury zone problem, and there is a pain. You remove the vascular compression, it goes off. ABT Adams stands up. ABT Adams, I think you all know about ABT Adams, stands up in 1989 and fights with Professor Janetta. It is not so. There is, whether there is a compression or non-compression, trigeminal pain is because it is just like an epileptic focus from the brainstem. So what you guys do is that you go and rub at the root injury zone, then the pain disappears. So ultimately what happened today in the world, everyone is doing microvascular decompression. Everyone is doing microvascular. I know how Professor Takanori Fukushima fought with that, Applebaum, Peter Janetta, they all were there in 1989 World Congress in India. And I was there as a young student. I saw the full fight. Now, whatever said and done, whether the hypothesis went right or wrong, the procedure has stood. So the same way, now Professor Ibe is trying to put forward the hypothesis, and then we are seeing, what we are seeing is now letting out the CSF from the basal cistern does improve the neurological status over a period of time. So it is going to, because it's only the beginning, the more the numbers are done, the more the studies are done, the results will come out. But however, the surgeons who start doing it, like Wang is doing large numbers in a short period of time, is doing continuously you start doing it, then you realize there's a change coming. So I think there's no need to have a hard feeling of discussion about DC is better or this is better. But if you add the cysternostomy, then you find the change. So that will take some time for people to accept and understand. But in over a period of time, it should be good. Like I was telling about it, I know that I was very emotional with this hypothesis, but this is correct. Usually, now the same thing happened to spinal cord injury patients. If whenever I speak to the scientists who worked on spinal cord injury, they believe that methylprednisolone works on in the laboratory. But does it believe it? Does it work in the clinical? It is not so. So spinal cord injury is different. Trigeminal neuralgia is different. I say that trigeminal neuralgia, the thing is something to equal to our head injury with cysternostomy. You believe me that this will work out. This will definitely come true in about 10 years' time. Dr. Ike will see this. Whether you like the hypothesis, you accept the hypothesis, or you don't accept the hypothesis, everyone will start doing cysternostomy along with decompressive craniectomy. This is what's going to happen. Yep.
Thank you, Dr. Parthiman. Any other comments? Dr. Burhan, would you like to talk to Dr. Acharian about this? Any comments? Dr. Burhan,
Yeah. Actually, in Kuala Lumpur, I was listening to Professor Cherian, and I was so impressed. Actually, in my clinic, we don't mostly use cisternostomy procedure. But after Kuala Lumpur WFNS symposia, I believe that it must be tried. And before anyone, any surgeon who didn't try this procedure and who didn't see their patient's outcome, they don't must to talk. Firstly, doctors or scientists must be open-minded. And I'm so appreciate Professor Sharon for teaching me this procedure's importance. Thank you for everyone.
Thank you, Dr. Burhan. Any other comments? Dr. Bankole, would you like to ask anything? Dr. Bankole. Dr. Bankole, would you like to ask anything?
No. It's okay. Okay. Yeah. Thank you very much, Professor Parthiman, and all talker today.
Thank you. Okay, so I think that's it for today. Thank you so much, Dr. Parthiban, Professor Tariq, Dr. Cherian, to come up and join us in this symposium. And thank you for all the participants and panelists. Thank you, John. And I think that's it for today. Thank you so much for making this a successful event. Yes, Professor. Yes.
May I request one thing again, please, to you and to John Bennett, and to try and advertise the ICRAN 2019 7 to 10 March in Peshawar, Pakistan, and to continue this discussion, if I may say.
Sure, Professor Tariq. Please email me the whole program and I'll...
Professor Tariq, I want to, this year we have ICRAN to Napoli, but I don't know if you be there, if you was been there in Napoli.
Yes, I was.
This year, okay, because me too, I was 2 months and I saw ICRAN, but I hope next year I will be to Pakistan.
We would welcome you in Pakistan. It'll be great.
Okay, thank you.
Thank you all. Thank you so much. So we wrap up for today. Thank you, everyone. Goodbye.
Thank you.
Have a good night. Bye.
Night.
Bye.
All right.